So let's just debo again then. Okay, try there. Advance it there. Advance करें. Advance करें. Still the same. Okay, why don't we just do a bit more filling? So थोड़ा सा इसको fill करके देखते हैं कि where is the actual takeoff. Is it because of the stricture there, isn't it? Wire दीजिएगा, then try again the wire. जाने दे wire there. See भाई advance करें. अच्छा, just a minute. So we might have done a cut in the. अच्छा. Still the cystic there.
नहीं आप करें. I'm going to use the wire. You go ahead. Go. वसीम को जो है ना ये ठीक नहीं कर रहा. I think we should come out a little bit more, just like without changing. Okay, now small wheel all the way towards you, all the way, floor. Okay, let's go in a little bit further. Does the tone go in? Yeah. Okay. थोड़ा सा out चलें. Out. That's fine. Floor. That's a cystic duct. Okay, it's a very, very low. Pull it out a little bit further. Okay, right there. Okay, I'm gonna bow. It might come out, but let's see if we can maintain. अगर आप थोड़ा सा push करें उसको, थोड़ा सा out into the patient. Keep pushing. Okay, stay there. Okay, pull the scope back a little bit. Let me unbow a little bit. Okay, so दोबारा करें इसको, maybe tip.
Khalid,
G.
why don't you leave a wire there in the cystic duct and go in with a second wire?
Yeah, we can do that as well. And let's we may have to use a curved wire.
Low origin of cystic duct is not uncommon in Pakistan.
थोड़ा सा उसको चेंज करें डायरेक्शन को. है एक और कर्व वायर है. हाँ वो उसको.
What did you try?
नहीं आप कर लो. Okay, you do it. Okay. हाँ जी, आप एंगल्ड वायर ले आओ. इसको पहले मैं एक दफा कर लूँ. एंगल्ड वायर नहीं नीचे. Right there.
I mean, let me just get my position a bit better.
Okay. Yeah. Small wheel a little bit towards you. I know it's an unstable position. Yeah. Floor.
PD possibly.
PD.
No, that's a PD.
Yeah, I'm sorry, out.
Mhm.
This is PD, isn't it?
Yeah, it's PD.
Yeah.
Yeah. Go in. Good. No. Okay. है बार आ गई? हाँ जी, ये चेंज कर दो.
Yes.
So I think
So,
so we
this
can-
is at an angle, like an angle Y. Yes. Okay. Okay. It's a really low takeoff, so we should be able to.
just a second, sorry. Bring the back a bit. Yes.
Section जरा wash कर दो उसको जरा. हाँ, wash करो. wash. Okay. ठीक है. Now, जहाँ भी चली जाए वायर अगर if it goes in cystic duct, just take it and we'll do a sphincterotomy. Extend the sphincterotomy a little bit.
Advance the wire there.
Right there. Good.
Advance can I? No. थोड़ा सा पीछे कीजिएगा वायर को प्लीज. यहाँ पे एडवांस कीजिएगा ना. नहीं, इस दिस डायरेक्शन ये दिस वन देयर. नहीं, नीचे जा रही है. Possibly PD. यहाँ पे एडवांस करना. ना, ये वायर पीछे रखिएगा प्लीज.
मुझे बता देना जब आप. That's a sphincter above that.
ये
Right there.
डालने एडवांस करेंगे.
No, I think it's outside.
Yeah, that's
Yeah,
the one.
right there.
Yeah, that's
Right there. Okay. चली गया? Flora? नहीं, पूछो.
एक मिनट कीजिएगा. Just a second. वायर पीछे रखिएगा. एडवांस कीजिएगा स्लोली. टिप लाइएगा, दीजिएगा, टिप दीजिएगा.
इसको थोड़ा सा लेफ्ट की तरफ वायर करो जहाँ पे वो रेड वाला है ना, लेफ्ट वाला एरिया. थोड़ा सा टोन को पीछे कर लें और फिर जस्ट ट्राई टू डू विद द वायर ओनली. राइट देयर. ओके, ठीक है.
यहाँ let's give me the wire there.
I think that's above the sphincter, aren't it?
No?
Sphincter is at the bottom, right there. Oh.
Opening should be in between, isn't it? With the yeah,
No.
this one. Oh, نہیں.
No, I think it's still down there. I think that's the top of the sphincter like that. It's the orifice is still here in that area. And if needed, we can cut it further. Yeah, right there. Mm-hmm. थोड़ा सा support चाहिए सर. Okay. Right there. Mm-hmm. नहीं जा रही.
Let me just hand this over to you. All right.
अच्छा, we'll try फर्क मैं हाँ थोड़ा सा try कर लें and wash कर दो. वायर टिप देना बस. टिप को निकालो, उसको एंगल जरा ऊपर की तरफ करो. अगर ये नहीं जाती तो हम so can take a straight to the तरफ.
Hello.
Yes.
Khalil bhai, when would you use a taper tip cannula or?
Yeah, we can, but I just let me just give me a straight दे दो. Straight देना. Yeah, we can use that too, but I think we should be able to get with this one.
And just for the trainees, when in these cases, difficult cases, when would you say that's enough now for today, and then we can come back another day? Is there a, do you have a cutoff where you've tried?
So I think where it all depends on the indication, and also like how much have you tried.
Plus, I think we've also injected the contrast
Yeah,
in the CBD.
I think that should be okay because it's draining pretty okay, so I don't think that should be a problem. Okay, okay, wide though, long, a little bit more long, thoda sa aur. अंदर होनी चाहिए. गई है ये नहीं. नहीं तो नीडल लाइफ हम यूज कर सकते हैं. Now, I'm not pushing with the tome. I'm just trying to get an angle with the. Okay, आपके ये अंदर. ओके, कोई बात नहीं. नहीं, इधर ही ठहरो 1 मिनट. ओके. नहीं तो हम we can try a needle knife. गई है अंदर या नहीं? नहीं तो नीडल नाइफ करना है या कैनोला करना है? हाँ, नहीं जा रही आगे. ओके. हाँ, नाइफ दे दो यार. آپ نے کرنے نا
نہیں آپ
Dr. Khalid, when you do this needle knife, can you just explain what steps you are going to do?
So one thing is like here you look for the mount. We already know that it's been cut a little bit. I will move it around a little bit, see where my sphincter is. You can see the sphincter is right here under that knife right there. So I will open it up, expose a little bit more of a sphincter right there, and then I will go after the sphincter right here. And it's important to know, Dina, is that a knife? Important to know that your actual landmarks. Cut away. Okay. I will just I'm exposing it a little bit further. Okay. Knife ko wapas karo sara. Okay. I will expose a little bit there. See where exactly. So all this is my sphincter right here. You see that? And then we will cut the sphincter either from bottom or top down. I usually do like a dry run like that, like which angle it's gonna go. Knife. So here looks like this is all my sphincter right there. If I go from here top like that, looks like it's giving me a good angle. So I'll go ahead and do that right there. Have to be careful. One thing is like, क्या हुआ? नहीं, क्या हुआ? काम कर रही है? I think we're having a little bit cautery issues here. So, काम कर रहा है? Flush करना. And these sometimes can bleed as well, obviously. Okay. Okay. Stop. You can see the sphincter right here.
Yes.
Okay. So I'm going to do a little bit injection. Thoda sa injection karna yahan pe. So what that does is it's going to cause a little bit submucosal injection, but that would kind of help with the bleeding as well. Okay. Thoda sa aur then knife dena. Let me expose a little bit more. Okay, knife back. So this is all sphincter there now. Wire है या नहीं है? There you go. Okay. Yeah, it's in that duct. Wire चाहिए बस. One of the ducts, I don't know which duct is it. Okay. Try. G. Looks like it should be in the duct. Okay. I think it's all the stricture. हाँ जी, try करो. That's a duct. कौन सा? Yeah, वो यहाँ पे ये stricture है. That's हाँ जी. इंजेक्ट करना ज़रा. पहले पानी का निकाल लो. हाँ, ओके, रेडी. ओके, इंजेक्ट ना. हाँ, एक मिनट ठहरो. हाँ, दे दो वो. आई थिंक वी हैव कट द स्फिंक्टर को हमने कट कर लिया है. निकाल लो. इसके क्या like
I think she
cancer?
well,
Oh, we are
painful
suspecting?
jaundice, but bilirubin was around 17 and 18.
Oh yeah, so
So-
it's
so
like not a
likely-
real
yeah.
likely
Correct.
tumor. Yeah. Okay. Okay. Give me a wire. Hmm? Okay. बो करो यहाँ पे. Okay. Okay, अब डालो. हाँ, चलते जाओ. ठीक है, मुझे एक दफा अंदर जाने दो. Okay. अब जरा इसको इंजेक्ट करो. I think we're in the right place now. Inject करो. Gall bladders again, right? Yeah. तो ऐसा करें कि हाँ, स्फिंक्टोटमी पहले बढ़ाएं. हाँ, और फिर उसके बाद इसको अंदर डाल के फिर कर्व वायर डाल दें. रेडी?
That's what we were discussing here, Khalid.
जी.
I think sphincterotomy extension, and then hopefully that should do the trick.
I think we have a nice sphincterotomy now. We have extended quite a bit. We can see the duct right there inside. Okay, चलो अब वायर को पुल करो वापस all the way and then bow the tome completely. ठीक है? Completely bow. ठीक है? Bow. Okay, अब try करो. चलते जाओ. पुश करो. अभी भी उधर ही है. हाँ? Okay. चलो all the way back. Unless the duct is completely blocked. एक और काम करो. अब जो है ना वो मुझे दे दो curve wire. You see that duct, guys?
Yeah.
You can see the duct very well there.
Yeah. And I don't know if it's the cystic duct itself just and bile duct is really completely on the side right here. एक मिनट. हाँ. Try करो यहाँ पे. Okay. चलो angle ले. So you are clearly in the right place, and it keeps going into a system. I think it's just the tumor or whatever stricture is. It's just completely blocking the bile duct. Okay. So I'm trying to give a different angle to see if we can inside that area right here. Ready? ठीक है. चलो.
And
Just going back. Okay. अच्छा ऐसा करो कि बो करो इसको. हाँ, बो करो. I think it's right here. चलो बो करो और बस ठीक है. अब करो.
bit better.
No, cystic duct again.
Yeah. یہ نیچے طرف دکھانا. Yeah, that's a PD, I think, right? ہاں PD ہے یا let's try there. ہاں try there. ذرا وائر تھوڑی اور وائر دو. گئی ہے اسٹریٹ چاہیے وائر. یا I think that's what it is. Straight dena. So you're thinking if it's right here in this area, either it's a PD. Looks like there is some bile there. PD be down here. So let's try here. Yeah. Okay.
I was more likely to be PD if at all.
Yeah, but we'll try it.
Right.
But it could be PD, but PD sometimes could be in this area where I touched it, that red area. We'll try if it's a PD, it's fine. But I think try karo. Okay. ایک منٹ ٹھہرو. ذرا اس کو انجیکٹ مجھے اندر جانے تو تھوڑا سا اندر. اوکے ناؤ انجیکٹ کرو سر. یا انجیکشن جا رہا ہے. پی ڈی رائٹ. I think that's PD, looks like, right? Is the
PD dilated?
Is the PD, I don't know. Is the PD dilated, guys?
So
Yeah, that is dilated.
Yeah, okay. So
Yeah,
that's,
so that is a PD. So it looks like a tumor then, definitely. Okay. And ye iske upar ek wo thoda sa nishan nazar aa raha hai? Right there, huh? Let's try there. Take, give me that. Right here. It's a PD is dilated. I think it definitely is the tumor.
can we switch to the next room, please? And we'll come back when they've cannulated.
ایک منٹ ذرا واپس کرنا. یہ ادھر کیا ہے؟ وائر. No, it's out. Oh. That is just strange. Okay.
Assalamu alaikum, I'm Dr. Asma Yasin. We're doing 46 years old female with history of biliary colic. For around 3 weeks, she had history of cholecystectomy a month back. Currently, ultrasound is showing CBD dilated of 1.2 centimeter with multiple echogenic foci, measuring one of the largest.
So we had just started and we were going through getting the scope through the mouth and intubating the esophagus, and we're having some resistance with that. So I'm just going to show you how I do it. Again, what I would typically do is slightly different from Dr. Hassan, but I usually have my big wheel towards me or big wheel down and have a bit of an angle on the tip. Then I advance it over the tongue, and usually you don't get much resistance if you have a bit of flex on the big wheel. And when I get to the back, I will now extend my big wheel and advance into the esophagus. Now I will typically keep going at the esophagus, and usually when you're at the G junction, I would stop. So right here, when you can start seeing gastric folds, and drop my left hand.
Sure.
I'm going to have you do this in a second.
Sir.
But I'm going to drop my left hand, and first thing I'll do, especially in the patient who's not intubated, is make sure that I suction the stomach, right? Get all the liquid contents out so you reduce the risk of aspiration. The further down my hand goes, the more I'm going towards the fundus. So I'm retroflexing almost. Now I can lift my hand up and advance the scope, distend, look for the sort of the lumen of the stomach and advance my scope. Usually now we're going along the greater curvature towards the pylorus. I'm going to not go through it, I'm just going to show you. So right now I can't see it, but I know it's likely going to be below me. So I'm going to see it, if I wanted to visualize it, I would drop my big wheel. With experience, you don't always visualize it. You just keep going like this, and then you eventually drop your big wheel and you go in. But early on, if you want to see it, you may either pull back like this to see it, or if you keep going with a lot of big wheel, you just relax your big wheel and you see it, and that gives you an idea. But I'm going to bring it back to the G junction,
Sure.
actually into the esophagus, for you to practice dropping the scope, your hand down once you're in the stomach, and then bringing it up. Okay?
Right.
So we're in the esophagus. You have to be careful when you're in the esophagus. Advance into the stomach. And once you're in the stomach, now usually wash your lens, drop your left hand towards the feet. There you go. Okay, suction. Now distend. And take your left arm all the way up 90 degrees. And keep distending and keep advancing. Usually you'll see the lumen better than this, but there's a keep advancing your scope. But you should see better. Section this, section all of this. And now distend. Are you sitting on the CO2? Distend the bow.
Sure.
Okay, pull back. So you see, is your big wheel relaxed?
Sure.
Okay, section. Okay, you have to see. This is too blind. So distend. Good. Now you can start seeing lumen, right?
Sure.
So now there's your pyloric channel. So you're gonna keep going in that greater curvature. So keep advancing. Good. Keep advancing. Keep advancing. You're making a big loop in the stomach, but that's expected. Keep going. Suction. Get rid of the bubble, right? There. And distend. You have to distend to see, otherwise you won't see what you're doing. But keep going. You have to go past this area. And now you're close to the pylorus. If you want to see it, you do big wheel away from you. So try, if you want to do big wheel away from you, you can see the pylorus. In reality, you may just keep going, but so big wheel away from you, there. And you actually just dropped into the duodenum like that.
Sure.
Okay, section, no blind movements, right? Advance, sorry, distend. Should be like next to each other. Okay, now you're going to stop. You can't just keep pushing, you're pushing against the back wall. So what's the maneuver you do?
So I turn the cock on the right side,
You're almost clockwise anyway. You're
Sir.
looking down the second
Sir.
portion. What else?
and then so I will turn the big wheel to the right, small wheel to the right, and lock it, sir.
No, you won't. You will do big wheel,
Big wheel towards me.
Yeah. Okay. And I want to show this for a concept. Right now, if you look at the fluoro, the big wheel you can see the tip of the scope is up against the wall. If we keep pushing like this is how perforations would occur in this duodenal apex area. Now go ahead and do big wheel towards you. Okay? And I'm going to do fluoro. And you've come off the wall. Now you've taken that turn. So that's what big wheel does for you. Okay? So when you do your big wheel, you're actually getting off the wall because you're looking sideways, right? And you're going towards the lumen. Now you basically have the big wheel towards you, and you can advance a bit more because it's safer to advance. So So push forward a bit. And if you think that you can't go anymore, now you will do small will to the right. And you will, there you go.
Can I lock it, sir?
Yeah, no, don't lock. We're not locking anything right now.
Right.
Okay? Just big wheel slightly towards you, and now you're going to reduce the scope. And don't have too much tension on the big wheel as you reduce. You have to be willing to let go of it if you get resistance. So big wheel towards you and reduce the scope. Go ahead, reduce. Is there tension? Because you're the one feeling the scope. I can't feel the scope.
No tension.
Usually I would have wanted to go a bit further, but let's just see. So if you don't have tension, keep reducing.
So can I move it a bit away, sir, the big wheel?
Yeah, you don't have to have extreme.
Because to keep it inside the lumen, in my view.
You don't need to have a luminal.
Right,
view.
sir.
You actually need to have a feel of this. If it's tight, you need to relax.
It's not tight, sir.
Okay, then gently reduce the scope.
I'm
reducing.
worried about this red out, sir.
I know, but that's a side view scope. It's a feel thing. Resistance or not?
I don't have any resistance,
Then
sir.
gently keep reducing.
So I may fall back.
It's okay. If you fall back, you can go back in.
Right, sir. So can I insufflate air some of the air?
Yeah, you can insufflate. Reduce the scope. You can't stand there.
Sir.
Okay. There you go. Keep reducing. Keep reducing.
So I also have to give the clockwise torque.
You have to be careful. As long as you can. I wish you could see a bit better, but I think you're just being a bit too nervous. That's what it is. Are we falling back or what's going on?
So I'm pulling back.
Okay, keep pulling back. If you fall back, we try again. That's okay. Keep reducing slowly. Small wheel to the right, I think. Okay, we're about to fall back. You see that on floor?
Sir.
Okay, so now just relax your big wheel and fall back. That's the safest thing you can do right now. Just pull back, come into the stomach. And you're going to try this again. So drop your left, get back into position, advance, big wheel towards you. You got to see the lumen suction, right? This is no different from any other endoscopy where you have to have a luminal view. So distend the stomach. Distend stomach, advance the scope. There you go. Good. Keep going. Relax your big wheel a bit.
So relax means move it away, sir?
Yes, big wheel away from you. Okay. There. Okay, distend. Get rid of this fluid, right? Okay. Distend. Okay.
Sir.
Small. It's a big wheel towards you. Right. Advance the scope. Not too much. Middle ground.
Right.
Okay, for both. Advance the scope. Big wheel towards you more. To allow it to advance. Keep advancing. If the big wheel keep advancing. There we go. This is better than last time. Keep advancing. Keep advancing. Big wheel towards you.
No,
Okay.
sir. It is not moving forward.
Okay, that's okay. Now you're in a better position to reduce. Now you're going to do small wheel to the right, big wheel towards you, and reduce the scope. Okay. Keep reducing. It's okay. Keep reducing. Big wheel towards you. The slower you are, the less stable it'll be. You have to speed up a bit because it'll be more stable there. Sometimes in that whole being slow, you just lose your position. There we go. Now it's getting reduced. So you can see a better luminal view. Good. Keep relaxing and small wheel to the right. Small wheel to the right. Good. And keep reducing a bit more. Good. And there's the papilla coming into view. In all my years of training, this may be the slowest reduction in the duodenum I've ever seen, but you got there.
Sir.
So that's a good part. Okay, look, now we're perfectly looking at the papilla, right? So that's excellent. So now what do you want to do?
So I would like to the synchrotome.
Did you study the papilla yet? So distend your duodenum. Distend.
Mr. Roy, that was a very nice display of reduction.
Yes. Good. No, he did excellent. And you have to be cautious initially, and then as your experience gets better, these movements just become second nature to you. So pull back the scope. It's okay for the scope to move back and forth. So pull back your scope because you don't know how big this mound is, right? So to get a sense of the mound, you have to pull back and back away with your big wheel. Back away with your big wheel. The orifice looks good, right? But we don't want to jump to the orifice without studying the whole situation.
Sir.
So go ahead and relax the big wheel and pull the scope back towards you. Okay, get a sense of how big is my mound. What is the sphincter like that I'm going to cut? Brightness, thodi kam ho sakti hai?
So it's a flat papilla, sir.
Looks flat, but as Dr. Hassan said yesterday, sometimes it looks flat, but actually when you...
So what would be the exercise? I can't figure out, sir.
Yeah, so I think that's why you need to pull back a bit more.
Sir, scope?
Yeah, pull back the scope. Relax your big wheel. Big wheel away from you.
Sir.
Get above it a bit. This is now you're doing the opposite of what you do for cannulation.
Sir.
To study it, you have to get above it. So you have to pull back. And actually that mound is pretty decent because if you look at it, all this is mound.
Sir.
So you have a pretty decent sized papilla, but I agree with you that, or sphincter, but the actual thing is pretty flat.
So that the column of the folds is moving up.
I think so,
in the direction of the 1 o'clock.
To be sphincter,
yes,
yeah.
Sir.
Yeah. So we have to
11 o'clock, sir. 11 o'clock.
Yeah. We'll have to see how it looks when we cannulate, but this is it. Your position overall is not bad, actually.
So should I?
But now you can take your tone, but you'll have to get underneath it a bit because we pulled back intentionally to look at it. To push your scope in, that's better. For now, I would stay there and take the tone.
Sir.
Tone there.
Sure, ma'am.
Or wire consi. I like 025. I like 025. You have to give us Vizzy here. Straight Vizzy there. So everybody has a preferred wire, and some people don't, and they're really talented. Dr. Sadniaz pretty much gets it with any wire, but if you do have a preferred wire, it's okay to just ask for that wire if you don't have that offered to you initially.
Sir.
And so in this case, we're going to go with the clever cut tome from Olympus and then a Olympus 025 VisiGlide straight. Yep. And then these devices all have markers that have meanings on them. So the clever cut and almost all Olympus devices have a little black part where you know that it's about to hit the elevator. Look at that. If you look down here, if you look down on your hand,
sir.
When you see this black area, then you know that you're getting close to the elevator.
Right, sir. Right, sir.
So you can just...
Now it's knocking.
Okay, yeah. So now you can gently sort of relax, open your elevator, and advance the tip out. But you're not going to start cannulating till you have...
wire is moving.
Yeah, but where's our... okay. Pull back. Is your elevator closed or open? Lift. Yeah, I think because our elevator wasn't closed.
Sir.
So your elevator has to be completely closed for the tone to come out. Once you hit... Okay, now slow down. No, slow down. Okay, there. That's what you want to do, this much. Are you sitting on your CO2? Distend the valve. Are you distending? Are you
yes,
sitting?
sir.
Okay, good. You have to respond so that we know.
Sir,
right?
sir.
No, that's fine. So now what you want to do is get into position. This is not a pretty good position. We don't want to get too excited here, right? The temptation is let me just go for it.
Sir.
But what's your maneuver going to be? What is your... Talk me through what you're going to do here.
So first of all, I'd like to bring it orientation with the that line, that imaginary line, sir.
Okay.
And that is going right up to the 11 o'clock.
Okay. So what, like...
Sir, I would just like to do like this. And...
So actually that takes you away. You're actually in pretty good position. The only thing I think you may want to consider doing is advancing the scope a tiny bit, and that'll get you underneath it a bit more.
Right, sir.
So go ahead and advance the scope in a bit. Good. Now that gets you under it even more, so that sit on your CO2.
So now I
wash your lens. So your lens.
Sir, I'm washing, sir.
Good.
Sir.
Okay. Now suction.
Suctioning, sir.
There you go. Okay, that's better. Now, the maneuvers that we talked about in the other room, how will you get close to the papilla?
Sir, you'll bring the big wheel towards me.
Okay, don't do it yet, because And are you going to go with the? There are all these different things you have to decide up front.
Sir.
Are you going to go with the sphincter tome, or are you going to go with the wire tip?
Sphinctotome, sir.
You're not going to go with the wire tip?
No, sir.
Why not?
Sir, I'm more comfortable with this.
What's more? Wait, how many RCPs have you done?
Sir, 50.
How many have you done independent? So how can you say you're comfortable when you've only done one,
Sir.
right? You don't know, right?
I don't know, sir.
What's the data? What's supposed to be better, wire guided or sphincter tome?
Sir, I don't know.
You shouldn't. Okay, so you need to know that. What did Dr. Hassan say yesterday?
So wire guided.
Then why don't we do wire guided?
Sir.
Right? Okay, so we'll take the wire tip. Okay, so all these. This is for all the trainees. These are not questions that we need to be answering in the procedure. This is data that you guys need to know
Sir.
if you're going to do these procedures. Okay, sit on your CO2 so you're distending.
Sir.
Okay, so before we do anything, what maneuvers, can we give some atropine, something to reduce the motility? So, what maneuvers take us up towards the papilla?
Sir,
Don't do anything, just tell me.
Sir, I will.
Verbalize.
So I will advance the scope. It will move the papilla up, sir.
So you did that already. We did
Sir.
that, right?
Sir.
Number 2,
Sir, then I will move the big wheel away.
big wheel away or
Sir,
towards?
sir, you want me to make the papilla away from the
You
scope?
want to go, you want your device to go up towards the
Sir,
papilla.
sir, for that matter, I will first of all have to use the bridge, elevate the bridge,
Okay.
and sir, bring the scope towards me, pull it. I mean,
Okay, so
and,
let me just recap so that,
sir.
because I know you're under pressure here. It's not the
Sir.
intention.
sir,
So, firstly, you want to get a good view. So that's why to reduce the motility, we're giving some atropine.
sir,
If you're too far up, the first thing you do is you push the scope in, which you already did.
sir,
The second is your elevator up. So when you do, for me, just go ahead and do elevator up and down. That's elevator up and down. See that? Relax your elevator. That's this.
sir,
Okay. Third, which you're not going to do right now, is big wheel up and down. Big wheel up will take you up towards the papilla.
sir,
So big wheel down will take you down
Sir.
away from the papilla, right?
Sir,
So
sir.
that's your third maneuver.
sir,
And the fourth one, if needed, is bow. You can bow up and down.
sir,
And people call it flex, bow, whatever. But the point is, you can do either of those. So you have
Sir.
these 4 things you can do. Right now, the problem is there's a lot of motility because we've been here and it's kind of stimulating.
sir,
But are you sitting on the CO2? Just distend. There you go. Once you distend, you can see better.
sir,
Okay, now what you're going to do is we have the wire tip. Your goal is to advance the scope in a tiny bit. Wash your lens. Get rid of that.
sir, wash it.
Okay, advance a bit. Small wheel to the right. Align yourself. Okay. Not too much. Okay, I think we were in better position earlier, but it's okay. This is not too bad, and you're generally going to advance the tome and lift with your elevator to engage it. But we have to see better. I think I would pull the scope back a tiny bit.
Right, sir, pulling.
Okay, be careful because
Pull.
yeah, that's good. Okay, stay there.
Sir,
Okay,
Can
the
you
other
hold
thing
the
is, you know the
scope?
difference. If you push too hard, you'll get water.
sir,
If you push, cover with your finger, you get air.
sir,
So you just want air. Okay, small wheel to the right. Because again, you want to go towards that 11 o'clock, right? Okay, good. Now, there you go. That's better. Now you're going to advance your tone forward to make contact with the orifice, with the wire. Okay, that's okay. Almost there. Keep going. Wire towards the orifice. There you go. Okay, too much. Okay, slower movements. But that's reasonably good. So, wire jari ke nahi jari? Okay. So I think we have too much tome out personally, and the tome. Are you pushing it?
no, sir,
Okay.
sir,
Pull it.
I just lifted the tome.
Okay, pull back on the tone. Because right now we're not in no man's land, right? Pull back. It's okay. There you go. Advance the tome a tiny bit. Just a fraction. You have to have control. Now advance wire, and you're going to lift the tome with to make contact. Okay. गई है तो now अभी भी जारी के रुक गई है रुकी हुई है ठीक है she's stuck right
Sir.
so now आपने इनसे कहना है कि I will advance मैं advance करूंगा और आपने pull करना है she is pulling you in so
Right,
go
sir.
ahead and do that
Pull back, ma'am.
and you see you're using the wire tip as a guide to get into that the other thing now you can do is stop both of you stop
Sir, sir,
I
stop.
think I don't know if you're in or out. मुझे लगता है कि we slipped off. But the next step would have been you also do gentle big wheel towards you with that. I think right now we're outside. So you pull back all over.
Sir.
Yeah, pull back.
Right.
Try again, because I think you're not quite there. So you're going to try this again. Wire tip, advance karen. Tome. Are you on your CO2? Are you sitting? Yeah, good. Advance the tome forward. Pull him in. थोड़ा सा folds हैं तो which makes it harder. Gently pull him in. Pull back. Okay, now slight gentle big wheel towards you. Very gentle. Big wheel towards you. Which did you feel anything going or no?
No, sir. I have lost the papilla, sir. Papillary opening.
It's actually there. The problem is there's a little fold. I need this foot pedal exit.
So should I bring it back, sir?
I think we keep doing the same thing. That's the problem. I think. Sorry. Let me just see what's going on furrow-wise. Our angle isn't too bad, but I think pull back because we're not seeing anything. So use the tip of your wire back, tip of your tome to get rid of that fold on the left. See if that makes it easier for you to visualize. Wire back, wire back. So use that to just get rid of that fold. Yeah, let's go time. So move it to the side. There you go. And then you do big wheel towards. Push the tome forward.
Sir, can I move the scope also, sir?
No, just push the tome forward. What are we doing? Are we cannulating or are we using the fold? Okay. So I'm going to push your scope in a bit to get you into better position.
Sir.
To get underneath it again.
So should I lift it up, sir, with the bridge?
I think you have to lift the tome up. Big wheel towards you slightly. Okay. Now, wire tip. We're still like, as you see, we're still a bit too far above. So I push your scope in a tiny bit more. Lift with your elevator and see if you can make contact. But again, it's going, let me just show you. It's going up like this.
Sir.
It's going up like this, and you're going down.
Sir.
So what you have to do is maybe push it even more to see if we can get underneath it more. Okay, there. Now see if you can lift a bit and see if the wire will take that upward. There you go. That's really good. Okay. Now she's going to pull back and you're going to advance.
Sir.
Okay, so you see you're making contact and gently advance. Gently advance. That's good. Gentle. Aram. Now big wheel slightly towards you. Slowly. Okay, big wheel slightly towards you. आप टोम कर रहे हैं पुल अपना?
जी sir.
Advance करें. Okay, good. Just now she's basically pulling you in to engage into the good. Now we're engaged. Wire, resistance. Okay, a bit of injection. Can you advance the tome more, or is it resistance?
Sir, I can't. I think.
Okay. Stop. Okay, so we see two ducts. You see the problem here?
Sir.
It is an extremely pulled over. So this is where you would need to pull your tome back while maintaining your access. So the elevator should be towards you, so that elevator should be closed basically slightly.
Sir.
As you pull back your tome to straighten this out. So elevator, keep it up inside the orifice and gently pull back your tome. And if you lose access, that's okay. But the maneuver is that.
Bring it back, sir.
Yeah, but don't pull it out. You have to bring it back while maintaining your access. So what you have to do is pull back. The other thing you do here is gently, while maintaining your elevator forward towards the papilla, you pull back the scope a fraction. Okay, let's see if that helped us. Oh, no, we're kind of out, I think, actually. I think we slipped out. So distend, too much motility. Let me take over for a second.
So we're inside, sir.
Were you in?
Sir.
So you have to tell me if you're in or not.
So I didn't have any idea at the time, sir.
Okay, wait a second. Then we're all outside. It's okay. It felt good, but unfortunately it wasn't the case. Okay, let's just get reset again. You're going to just be free with your movements.
We like to switch to the other room because Dr. Khalid is there doing the Endoscopy.
So,
Khalid, we are with you.
Oh, you are with me now. You see the tumor, guys?
Well, we can see you, but we cannot see the screen.
Can the spyglass?
Okay, good.
We are in the bile duct, but I wanted to show you the tumor. Can you show the colonoscopy, guys? Colonoscope की दिखाओ जरा.
We can see this.
You see the wire up there, right?
Yes, we can see the wire up. Yes.
Fluoro दिखाना. Yeah, you see the wire in the intrahepatics now, but I want to show you it's like completely obstructed by the tumor. नहीं वो उधर से नहीं दिखा सकते. इसका नहीं है. अच्छा
पिक्चर नहीं है इसकी.
इस कैमरे को इधर लेके आओ और दिखा दो जरा. I think this is not connected, so move the camera here. And उस पे नहीं डाल सकता ताकि वो इसी पे आएगा. अच्छा चलो ठीक है. आ गया. अच्छा.
Okay, we can see the.
Yeah, you see there is really no space there whatsoever. That's all tumor completely obstructing the duct, bile duct orifice. So he got that angle with the colonoscope, IMAX, and then pushed the wire and it went straight into the bile duct. Right there. You guys can see, right? Any response?
So are you operating over the wire now?
Yes, it is over the wire, and even my spy scope is giving a little bit trouble getting through that because it's so tight.
Yeah, we can see that. Yeah, we can see the wire.
That's
now.
all tumor there.
So what's your plan? Are you going to take the biopsies, or are you?
Yeah, I think what we're going to do is like either do a brushing or biopsy of this, so we know at least have an idea. We should have done a EUS on him too, but we can put a stent, plastic stent in there. You see that tumor now, right? Clearly.
Yes, we can see the tumor. Yes.
Yeah. So I think what we'll do is let's do a cytology brush. First, we're going to exchange. Leave the wire there. Do a cytology brush, and then after that, we can either do a EUS too.
Khalid, there's a question there. Why don't you take a biopsy directly under vision?
Yeah, I think we can do that as well. But the problem is going to be getting the biopsy forceps there. We might have a little bit trouble. Yeah.
This is a 9 mm scope.
And you see that right there. Oh, you mean through the spy scope biopsy?
Yeah, through the spy scope. But
this is a
you'll have to remove the wire, which is not
I think
advisable.
The problem is going to be, one thing is we barely got the wire through, and that's an issue. Other thing is it's a smaller scope as well. And putting that spy bite is going to be a problem. किधर है? फ्लोरो को कोई प्रेस कर लो यार. Okay. पुश करो वायर को. Okay. पुश करो वायर को. पुश करो वायर को. पुश करो वायर को. 1 मिनट ठहरो. Okay. 1 मिनट ठहर जाओ. Okay. Right there. Okay. Good. Okay. चलो. We had a really rough, as you can see, that getting the wire through that was not easy. What I'm going to do is I will put a do a burst cytology first, put a biopsy forceps alongside the wire, regular biopsy forceps, choti wali hai biopsy forceps, or a pediatric biopsy forceps, biopsy alongside the wire. And then we'll just put a stent in there. And if you guys need to go to the next one, that's fine. We'll ready. और पहले साइटोलॉजी ब्रश दे दो. आपने करना है?
Shall I do it for you?
Oh, yeah.
No,
of course.
Thank you.
हाँ जी.
I guess you're tired, sorry.
No, I'm not tired, but you should take over. अब देख लो, देख लीजिएगा. ठीक है. یہ مائک نکال
واپس دیکھ کانفلکٹ میں ٹاس کر دو.
So the cytology bridge.
So Nadeem, we are with you. Nadeem, can you hear us?
Ji, sorry. Are we audible in the room as well? Ji.
So are you going to use the brush?
Ji, we'll do the breast cytology first and followed by pediatric forceps biopsies.
हाँ कोलोनोस्कोप निकालेगी कोलोनोस्कोप
ये देखिएगा C2 जा रही है. Fine. Okay, so let's just. Okay.
Just a minute, ma'am. Now it will be coming out. No, just a minute.
That's fine. Yeah.
Now it will be coming out.
Good. Keep going. Now you see the stones are in the distal duct, right? Keep going. Good. Keep going. Good. Keep going. And let's stop. I would just start here in the distal duct. So, what do you think the size of that duct is?
Almost, sir, between 11 to 12.
Our scope is about 13.
13,
right?
sir.
So if you look at it, it's slightly bigger than the scope. So I'd say about 15.
Sir.
Right above the scope, it looks around 15.
Sir.
So you want at least a 15 balloon. Okay, good. So balloon up. This is at 15.
Sir, we start from the bottom.
Usually you start at the bottom. We're in the middle right now.
Sir.
If you want to start lower, we can put it down. But
Sir,
I think you'd be okay.
right, sir. So should I start
Yeah, go ahead
sweeping?
and sweep,
So,
yeah.
I'm coming back, sir.
Yep, good.
Coming back. I'm counting resistance.
Your resistance.
So Mustafa, we are back with you. What is the pathology that this patient has?
So this patient is post-cholecystectomy with bile duct stones. So if we got in, I think just after you left, is all as often is the case, we got in and did a sphincterotomy, and now we're just starting to balloon sweep. So you want to stay below the sphincter bit. So you push the scope in a tiny bit. Okay, there you go. Because you want to stay in the trajectory of the duct.
Sir.
And you want to pull back. The balloon is pretty big for our duct actually at this stage. So balloon thoda kam karna. Okay.
Sir, should I
And
do the maneuver now?
Yeah. Do you have, how much resistance do you have?
Sir, bit of.
Okay.
I have resistance now.
Okay. So now you're going to lock the balloon in your left hand. Lock the balloon in your left hand. Wait.
Sir.
And now gently, small bit to the right. Let's push scope in. And if you still have resistance, we may have to push the balloon down a bit more. Okay, good. That was good. Excellent. Balloon down. Did we get anything or nothing?
Sir, nothing.
We have to reduce the balloon scope. Reduce your scope.
Sir.
I agree with you. Nothing on this pass, right? So let's try again. So we go in further. Because we were told multiple filling defects, and I thought initially we saw some. So we'll
Pull
go
back,
up higher.
Pull back. Pull back, ma'am.
Pull back. So you just keep advancing. Your elevator should be open, and you should be able to advance
Sir.
easily. So keep advancing. Keep advancing. Advance the.
Sir. So I want to bring it in view.
No, you don't need to bring it in. Advance.
Right.
You have fluoro. You have to do. It's a feel thing, right? If it's
Sir.
going, then you know it's in place. Okay, there you go. Now you're up at the hilum.
Sir.
So you're going to try balloon up again.
So that marker shows the part of the balloon.
Exactly. And the balloon will be above the black marker.
Right,
so
sir.
Balloon up. 12. Yeah.
1 point will fit.
Okay. Okay, balloon is up.
So
Now
should
go
I
ahead and-
start the
yes,
sweep, sir?
Start sweeping again. Yeah.
Okay, I'm sweeping, sir. I'm bringing it back, sir.
Okay.
It is not giving me any resistance up till this moment.
Okay.
It is not giving me any resistance, sir.
Okay.
Should I keep sweeping?
Yeah, you keep going till you either see stone or balloon. And so when you get to the bottom, you're going to lock it in your left
So
hand.
I think I've reached the bottom.
Okay, so lock it in your left hand.
Sir,
A lot of bubbles and whatnot, motility. And then you're going to distend and right and push scope in. Anything or nothing? A lot of blood coming out. Keep going. So pull back on the balloon a bit more. Are we out already or no? I can't tell. No, you're still in the sphincter area. Balloon down at thoda sa comfort.
ma'am, can I see the balloon on the floor? Can I see the balloon on the floor?
Yeah. There. In the distal duct. So
Sir,
yeah.
the maneuver should help, sir. Or?
Yeah, go ahead and push scope in. There you go. Keep pushing. There. Now, as soon as it's down, you have to pull back the scope. Balloon down, pull back the scope. No stone, right?
Sir, no stone.
Okay, let me take over. So we've
Sure,
done
sure.
2 sweeps without any stone. The question is, was there any stone, or what was seen on ultrasound was either sludge or, artifact. The other annoying thing is bleeding, which we have to decide if we have to do anything about here. I'm just trying to distend just to get a better view of the sphincter here. You have to be patient. Just stay there. Keep distending. Make sure your cap isn't leaking air. So that's our orifice. I don't see major bleeding, but there's certainly some oozing going on. I'm going to do one more sweep, or actually do an occlusion maybe, and then. Thank you. Okay.
So, Mustafa, what do you think? What's the pathology?
I don't know if it's like papillary stenosis or something. I'm going to inject here, make sure we don't miss a stone balloon. Actually, without inflation, just inject. Yep. Good. Inject. Okay. So the reason I'm injecting without inflation is I don't want to push any stones up. I see a lot of air bubbles. I don't see anything obvious. Now that I'm pretty confident that I haven't pushed anything up, I can now do balloon up. Balloon up. Balloon up. Good. And then inject it. But we're going to inject it gently just to see if there's anything up there. But I think, honestly, if we don't find anything on this third sweep, we're just going to stop. And
So, to be honest, on the top, we don't see anything.
yeah, exactly. What I also don't want
it's coming out very easily.
Yeah, so stop.
It's a smooth one.
The other thing is, when you already have a traumatized papilla, you've done 2 convincing sweeps. At this point, I'm actually not going to do another sweep because I'm pretty sure there's nothing here. So I'm just going to say balloon down, not to traumatize this. And then the final decision here is whether to do anything about this bleeding. It's already stopping.
I think maybe tamponade for a couple of minutes and that's it.
Like a balloon tamponade?
Yeah, balloon, even
Using the same balloon?
If it's
or?
a young patient, I shall say that doing nothing will be okay.
Yeah. Would you use this balloon or a proper
No, just this balloon. This
okay. Okay, then we'll just do balloon up here. Actually, balloon down. Slowly right here. Balloon up. Yep.
So it's getting
So I'm going to give back tension to try and get that area, but you either end up going above or below it oftentimes. I might have to do it from the outside too, I think. With a stone extract, with a dilation balloon, obviously you have more control of this process. But honestly, Dr. Gas, I think I might just leave it at this point.
Yes, I agree with you that there's nothing really.
Yeah.
So Yesterday as well, we were discussing that elderly patient pulse style bleed. There's every reason to go for hemostasis.
Yeah.
Young person with a capillary
यहाँ पे
use,
थोड़ा सा
to be honest, there's
हल्का सा
nothing really to worry about.
Yeah. We'll just try once quickly from balloon. हो रहा है कि नहीं? अच्छा balloon कर नहीं balloon कर देंगे balloon up. वैसे रहने दें कि bleeding तो रुक गई है. So I think we're just going to pull out.
So why is this duct dilated? Seems to be dilated.
She may have had a stone in the past. It's not clear to me. Or she may have had a stenotic papilla, which is always an unsatisfactory answer, but might be the case here.
Sir, will occlusion cholangiectomy help if the dye has to be washed out completely?
No, because we have such a big sphincterotomy, it'll come out. So I want
Sir.
you to withdraw the scope. And
Sir.
the main things there are, when you come out, making sure your wheels are unlocked,
Sir.
and then come to the stomach and you empty the stomach.
Sir.
Okay, so go ahead. The wheels are unlocked. Good. Keep pulling back. Keep pulling back. Keep pulling back. Now, sometimes you can have a small stone that you just don't see. So, in my reports, I would say a small stone cannot be excluded. However, on the cholangiogram, we did not see a stone. So now drop your left hand. There you go. And now you're going to suction from here up. You stay below the G junction. Push forward. No, push forward. Advance. There. Suction. Okay. And I just want to show the trainees, when you do that, what you'll see is that that gastric bubble should disappear. You see now it's gone. You see contrast in the duct, that'll make its way down.
Sir.
At this point, you can pull out the scope. This is also, if you're worried about a perforation, you want to distend, you want to decompress the stomach, keep pulling back, keep pulling. When you're in the stomach, esophagus, just keep pulling back. You don't need to suction.
Sir.
But if you're worried about a perforation, what you do is you decompress the stomach and you look under the left diaphragm to see if there's any free air. Obviously, if you're looking at, and you look into the right diaphragm for free air as well. But if you decompress and look, okay?
Right, sir.
But always decompress and so that when they wake up, they're not belching.
Sir.
Thank you. I think.
Okay. इसको 0 0 पे इसको 0 0 पे रखिएगा. छोड़ दो इसको. Thank you. There's a lot of air there. ڈاپلر آف لیجیے گا. ہاں جی ڈاپلر دیجیے گا. نہیں ڈاپلر آف کر دیجیے گا. یہ کون سی 22 ہے 19؟ ایک منٹ سے دیجیے گا. ڈاپلر آن کر دیجیے گا. بس ٹھیک ہے آف کر دیجیے گا ڈاپلر. اوکے ٹیلنٹ نکال لیجیے گا. ہاں پورا نکال دیجیے پورا نکال دیجیے. اسٹائل اٹ آؤٹ. اوکے کین آئی ہیو اے سکشن پلیز. ہاں جی سیکشن آن کر دیجیے گا. لیجیے گا. کیب دیجیے گا. تھینک یو. So this is obviously the stent going through the mass there. So the stent, yeah, that's the stent going through. Obviously, if there's a pointer there, caliper, or if there's a pointer, کچھ ہے جی ٹیشو. ہاں
یہ براؤن جو ہے نا
ہاں
دو
ٹھیک
تین پیس ہیں.
بالکل ٹھیک بالکل صحیح. ہاں ایک اور لے دیں ایک اور. اس کو تھوڑا سا 0 پہ لے جائے گی. Good views there. سیکشن دے دیجیے گا. آن نہیں کیجیے گا جس خالی لگا دیجیے. خالی اٹیچ کیجیے گا. Hmm? That's correct. Yeah, that's the area. Yeah. So you put elasticity is there? Elastography. Elasto on this. Let's have a look. That's fine doing it. I'll look on the elasticity. B mode पे जाए इसको. था कुछ नहीं था.
इसमें से कम आया.
अच्छा दिखाएं. खालिद भी कहते हैं 5 मिनट वाला करें. Let's just quickly do it. So I think you need to get another case here, isn't it?
पहले वाले में 4 आ गया.
सेक्शन दीजिएगा. अच्छा हाँ नहीं कीजिएगा बस.
We're going to be demonstrating one of the cases that we had done in the morning, but they didn't get transmitted. So for our audience, Dr. Wakar will just walk us through this case. Sir, if you want, I could just forward it ahead. If you...
ये बेहतर होगा. This should be good. ये बेहतर होगा. This should be good. Should be good enough. एक मिनट. Just let me have a quick look. اس میں تھوڑا اسپیسیمن ہونا چاہیے سیکنڈ والے میں. بلڈ ہے, چلو کچھ نہ کچھ ٹیشو ہوگا اس میں.
تو کینولیشن کا ہمیشہ ٹرائی ٹو میک اٹ ایز اور اس کو تھوڑا فارورڈ کر دیتے ہیں کیونکہ کہاں سے اچھا اچھا اس کا یہ کوآرڈینیٹ ہوتا ہے کہ الگ آ رہا ہے جو فلورو جو ہے جتنا خیال ہے کوئی ہاں یہ اچھا ویسے اگر دیکھا جائے تو مطلب اٹ سیمس ٹو بی پوائنٹنگ in the right direction, lekin the main problem was the wire was hitting the stone and it kept on getting deflected into the PD. So idhar ke ye kuch sare isko thoda sa aage kar do. Ha, so eventually what we did was we left the wire in the PD and tried to cannulate above it using the dual wire technique. One of the things you can do, the advantage of using dual wire technique is that you can, the first wire in the PD acts as your guide. So you can use that as a guide. Secondly, if you exert a slight pull on the wire, you can pull your PD down and separate the bile duct from it. اس کا وہ نہیں آ رہا تھا فلورو. ہاں اچھا یہاں سے چلانا ہوگا. ہاں but if you notice here you are constantly hitting the stone. یہ میرے خیال ہم پیچھے ہیں ادھر, اس کو بھی تھوڑا آگے کر لیتے ہیں ادھر سے. ہاں اور ہاں ہاں ٹھیک ہے, اور بھی تھوڑا کیونکہ میرے خیال یہ ہوا ہے وی آر گوئنگ. ہاں और भी okay, we have left the wire there. ठीक है, सही है. ठीक. हाँ. We went anyway. So the main thing was it was a dual wire technique. और जो challenges होते हैं, एक जो एक तो उसका था कि movement काफी थी, लेकिन खैर we overcame that and it settled down. Once we had a word with the anesthetist, they very kindly adjusted the anesthesia level. और secondly जो stone था उसको it was hit कर रहा था, तो उसमें ये होता है कि बाद वक्त थोड़ा आप कैनुला से पुश करने की कोशिश करते हैं उसको कि डिसलॉज हो जाए, और या वायर को मैनिपुलेट करते हैं. तो luckily we had Rima with us who is very experienced and skilled, so she managed to get it past. और
किया था कि your orientation over the PD wire is above and to the left.
Exactly.
Most of the time that's the case. Kabhi very rarely it'll go across to the other side. But if your probe is coming from below, you will not get bladder.
That's true.
FPD. So you have to, Dr. Wakar ne kaha tha, you have to push this wire down a bit by pushing the wire out of the channel, and then get the tone to go over the wire and to the left of the wire. If you can get your tone to come from above this PD wire and over and across, that is your best chance of getting into the wire.
सारा एम इसी का है, और यही इसका मतलब एडवांटेज जो होता है कि यू गेट इट एज अ गाइड, तो यूज इट एज अ गाइड. और दूसरा, ड्यूरिंग द प्रोसीजर you always should make maximum advantage of the observing the anatomy or the course of the papilla in the duodenum, क्योंकि उससे आपको ये होता है कि आप अपने वायर को या कैनुला को डायरेक्ट करते हैं उसी उसमें डायरेक्शन में. ठीक. हाँ, मतलब अमंग्स द ट्रेनिंग्स क्या क्या अमंग्स ऑपरेटर में भी होती है, कोई ऐसी वो नहीं है. इट इज अ हाई रिस्क प्रोसीजर, तो ऑब्वियसली, क्योंकि अगर इफ यू लुक एट द डेटा ओवर द लास्ट 30 years, बिकॉज ऑफ द बल्कि आई वुड से 35-40 years, there has been a very marked development in the technology. So that has brought down the complication risk in most of the endoscopic procedures, except ERCP. ERCP में it has remained static because ERCP procedure है ही high risk. अब जैसे बाकी procedures हैं उसमें बहुत कम हो गया है, जितने आपके additional वो technology, imaging quality सब कुछ आई है, तो उससे the risks are far less, मतलब significantly less. But with ERCP it's much the same, क्योंकि you are dealing with a very high risk situation.
उससे अगर पता लग जाए
नहीं, कोलेंजियोस्कोप का तो मतलब वो तो है ना, यू कैन यूज इट स्टिल नाउ, इट्स गॉट इट्स ओन इंडिकेशन ना. और बहुत पहले जो होता था, तो हम लोग जब व्हेन आई वाज अ ट्रेनी, so we used to use a mother and baby scope, which was a very crude form of a cholangioscope. मेरे ख्याल है और किसी ने यहाँ पे, I don't think anyone is young old enough to have used that, लेकिन हम लोग वो करते थे बड़ी सिंक्रोटमी करके मेन थेरेप्यूटिक गैस्ट्रोस्कोपी स्कोप में मदर वो बेबी स्कोप डाल के करते थे, तो वी यूज्ड टू डू दैट. या बाद वक्त बड़ी सिंक्रोटमी होती थी, तो we used to put a pediatric gastroscope through it. So that was our poor man's colonoscopy in those days. दूसरा, again, can never be stressed how important it is to maintain your line of contact during the.
ठीक है, you're doing good. Hello, can you see us? So at least papillary stenosis is not there. Hello, can you hear us?
G, we can hear you. Sorry.
People in the conference room, can you hear us?
I think Dr. Tayyib, Yasin Ali Tayyib was audible, but I'm sorry, Ali, we can't hear you.
Hello.
Gigi, sir, we can hear you.
Proceed. You have the position and
G, you are audible.
great. So I have Dr. Ali with me. He is fairly experienced. He has done about 100 cases. And he has done independently for 5 cases. Up till now, he has been able to intubate through the oropharynx very comfortably. He has gone down fairly quickly, and he has been able to localize the papilla in a proper position very competently. So here's the papilla. The patient has got attacks of recurrent attacks of biliary colic, and she has got stones. And the initial thought was that initially, before we entered into the patient, that maybe we're going to come across papillary stenosis or maybe a periimperial stricture. So papillary stenosis is not there. She's got she has been having recurrent attacks of pancreatitis as well. So Dr. Ali is trying to engage the papilla first with the tip of the wire, and then he's going to engage the tip of the papillotome. So though fairly nice position, but I would have loved to push the endoscope little down. Yeah, that's a reasonable. Yeah, that's right. So bring the papilla closer to, yeah. So a guide has gone in, and we have tried to engage the papillotome. Okay, can we have a look at the fluoroscope, please? So you see, right now, if you look at the direction of the papilla and we look at the direction of the guide bar, probably is pointing more towards the pancreatic duct and not towards the CVD. So what we need to do is that push the endoscope a little further and look higher up towards the CVD. Yeah, let's see, where are we? Guide bar has gone somewhere. Okay, so we're gone in the right duct. So now once the wire has gone up, so the first step has been achieved, that's the cannulation. And once the cannulation has been achieved, next thing is outlining the duct competently and saying what's the pathology. We already see that we have got really dense shadows in the right upper quadrant. So meaning by that multiple stones are there. So yeah. So can we have a look at the cholangogram? Yes. Okay. So it's fairly dilated duct. So you can see that possibly there's a stone right underneath the endoscope. Yeah, there's a papillary stricture because while going in, he had a little problem in pushing the tip of the papillotome up. So that's what we had expected before we had gone in. I was discussing with Dr. Ali that what are you expecting in this case? With the history that he has, possibly either we are going to find the papillary stenosis or we're going to find a stricture at the lower end of the CVD. Had this patient been in the age group of mid 50s or 60s, I would have recommended straight away taking the brushing as well. But in this patient, maybe a papillotomy and possibly a dilatation will be good enough. So we'll see if we find that there's something tight, we'll do the dilatation. Otherwise, doing a papillotomy will be good enough. Yes, sphincterotomy has gone a little to the side, but as long as you're doing it over the wire, what I'll do is that I shall do a couple of pushes, and then I shall push the cannula again up and bring it back, and push the endoscope a little down to bring it in line with the CVD. So as long as we're doing it over the wire, we know that the direction of the papillotome is good, but still, we to keep it straight, it should be everything should be in line with the CVD. Yeah, yeah, please further. I I always say that either you don't do the papillotomy. If you have to do the papillotomy, do it full, so that the patient may not come back a couple of years later with with ampullary stenosis, because if you cut the muscle incompletely, the patient is likely to come back at a later stage with stricturing of the lower CVD. Now you see the lower end of the CVD is a bit narrow. So in this scenario, are we going to do the dilatation or are we going to do just a sweep? We're going to decide it once we have done the balloon sweep. If we find that the balloon is getting deformed on a on a way out, that means that we'll need to do the dilatation. So far, Dr. Ali has done very well. He has completed the task. He's done the cannulation very competently. He has outlined the CVD very nicely. Now the next task is to do the balloon dredge. Any question from the hall?
So, what size balloon dilation are you thinking?
No, we are not going to do the balloon dilatation at this moment. We are going to just do the balloon dredge. If we see that there's a balloon deformity, I shall start off with a smaller balloon, 8 millimeter.
Okay.
Ali, what is your plan? Are you going to start off with 8 or 10 or 12 millimeter? What is your plan?
Right now, I'm going to have a visualization where I am right now. If I am in the distance, I want to do a balloon crawl of 10 mm from mid CBD.
Okay,
or
fine.
maybe from the lower CBD.
We can't hear Ali very well.
Yeah, that's
so-
good. So your guide was way in. So I shall like to pull back the wire.
Please pull back the wire. All right, thank you. So I'm trying to deliver my balloon, and I think we are close, and there it is. All right. So deflate, please. Thank you. I'm going in again. So I'll be going up now.
So roughly this is about 10 to 12 millimeter
Yeah.
duct. So see where you are. Yeah, exact. Good.
If you can pull back the wire. All right.
And a good thing about Dr. Ali is
Yes.
that he's continuously talking to
All
his
right.
tech.
Thank you. So now I would like you to inflate it to 1.2 millimeter. All right. And if you can start pushing the die as well. All right. Fluoro. Fluoro. I'm coming back. I'm coming back. Keep pushing the wire. The wire is coming out. Thank you. All right. All right. All right. All right. All right. Okay. So we are out. Deflate. And let's see if we have good flow of bile or not. Let's just wait.
So we're getting a good flow of the bile.
Yeah.
So meaning by that, even if it was a stricture, it was a soft stricture.
It was. I think we have cut the stricture as well.
We have cut the stricture.
Yeah. So
The strictures are fibrous, so you've cut the muscle. Stricture is possibly, I shall say that mild degree stricturing
I
is
think it's
there,
all
but
gone.
with this kind of picture, I shall just leave it alone. In case a patient comes back with a problem, only then we are going to
Yeah.
do some kind of further
I
intervention.
think we can do all out now.
Yeah, we can pull out the
Okay.
accessories,
Alright.
and then we can unlock the wheels and we can pull out.
Now,
So
thank
nice
you.
job done by Dr. Ali.
Thank you so much.
Well done. The
Very nice.
intubation Pepla was good. His cannulation was up to the mark. His was again up to the mark. Now the next management steps are obviously this patient should undergo colonoscopy and laparoscopic colonoscopy as early as possible,
Thank you, Renu.
not to delay it any further. Any question from the hall?
We're good, thank you. Excellent case.
Thank
Appreciate
you.
it.
Thank you very much.
Thank you.
Thank you.
Thank you.
Great. Thank you. Thank you, staff.
Well done. Excellent.
जी जी